Okay, Schaefer's putting on his mic. We have a really important talk, and understanding your CGM download. Forgive us for some of you folks that are pretty savvy, and for a lot of you may not take advantage of the fact that you have a CGM. It gives you lots of important data, and you should use that data on your own. Don't rely on just going to the doctor and having him or her analyze it for you. So all of these systems are, all of the different CGM systems have download ability. So while Schaefer's coming up here, here's your changer. Okay, we're gonna start. You wanna stand on this side so your monitor is easier for you? Okay, this is an important intro slide. CGM, and I have to tell this to the payers, the insurance companies, it is and has been the standard of care for people with type 1 diabetes. Jeremy and I have been pushing this way beyond over 5 years now. And it's been a tough battle with the payers. It allows for time and range metrics, which we're gonna go through. It is the most accurate way to determine your long-term diabetes control. A lot more accurate than the A1C that we get our blood drawn for the past 20 or so years. It's a very efficient way to focus in and hone in on the most important issue that's causing your diabetes to not be well controlled. And we talk to physicians all the time, and it's the same language that we speak to them as Schaefer and I are speaking to all of you. And it is the backbone of automated insulin delivery systems like hybrid closed loop, and very importantly, it is the backbone of all you folks out there on multiple daily injections, because you folks can do extremely well with a CGM and responding to the information that we're going to go through. Whoops, okay.
So the point of this talk really, Steve, is to kind of walk through how we approach looking at the CGM data as endocrinologists. And the idea behind it is that this is your CGM data, it's your blood glucose data. And if you can really understand what's going on using all of this CGM information, then it can empower you to make more informed choices, to sort of improve your discussions with your healthcare provider and to make adjustments to your insulin dosing, all sorts of things. So we want you to be able to go back and look at this. So of course you can look at your real-time CGM data, like what's your blood sugar right now, what's the trend arrow, what's kind of been going on over the last few hours. But in order to go back in time and sort of retrospectively analyze what your blood sugars have been for the past week, month, 3 months, whatever you want to look at, you can download the reports. So you can do this on apps, or you can do it on your computer with different programs. So depending on what CGM you're using, there's different sort of ways to do this, but they all have a very similar sort of system. And the information that you get in each of these situations is also similar. So we're going to kind of talk through the way that we would look at a download and sort of help you understand how to appreciate what's going on with your own blood sugars. So this is just a picture of an example from one of the phone applications that would show all of this information that we're going to talk about. So when Steve and I look at a CGM download, we do it the same way every time, just very methodically. So we'll kind of go a little bit piece by piece more in depth in these things, but this is real quickly how in 30 seconds or less we would analyze a CGM.
This is the exact same information we give to healthcare professionals, a methodical way to look through, and it may take a minute or two to go through it with all of you, but once you get used to looking at them, you can do it like that.
Yeah, and so we encourage you to kind of think about looking through your blood sugars and your CGM download data the same way. So the first thing we look at is the average blood glucose, right? And that's sort of, depending on what your download is set at, it could be for the last 7 days, it could be for the last 30 days, so that's one important thing to look at. But look at your average blood sugar. And there are some sort of general goals that we list here that are actually the goals that the societies recommend. Of course, everyone will have a different average blood sugar goal, and it depends on where you're starting, it depends on where you're trying to go. But in general, we shoot for less than 150 as an average blood sugar goal. And then the glucose management indicator, which is in a percent, and it's basically the estimated A1C. So that's something that's calculated based on your average blood glucose. Then we look at the standard deviation or the coefficient of variation. These are two different measurements of glycemic variability. So how much is your blood sugar sort of going high and low above or below the average blood sugar? And so for a standard deviation, the goal is less than 50. For a coefficient of variation, the goal is less than 36%. And those are just two different ways to calculate the same sort of thing, glycemic variability.
Just say real quickly on the Libre download does coefficient of variation. The Dexcom and others use the standard deviation.
So most people probably here would be looking at standard deviation, but if you happen to use a Libre, it comes in coefficient of variation. Then we look at time and range, right? We talk about time and range a lot, and we'll show you again the graph that kind of outlines what the different cutoffs for time and range are. But the goal for the amount of time that we want to spend in time and range is at least 70%. So higher is better. Like we want to get as much time and range as possible, but if we can achieve 70, then that's a very good place to be. And we want to minimize time below range. So we look at time in range, then we look at time below range. That's time spent in hypoglycemia, right? So time less than 70, and then there's also time very below range. What?
4%.
Yeah. So there's time below range less than 70, then there's time below 54. But you want to have less than 4% time of your day spent less than 70. So we really don't want to have a lot of hypoglycemia. And Steve's mentioned before that 4% of your day is 1 hour. So that's a significant amount of time that can be spent in hypoglycemia. So we really don't want to see that number to be 10%, 20%. Want to minimize the amount of time below range. After that, we look at the 24-hour glucose profile, and we'll show you pictures of this. But what this basically is, it shows all your blood sugars from that whole time period in one place. And it's a really good graph to just look at briefly and zoom into different areas and figure out where there's issues and things that you might want to address. And then if you need to, you can go in and kind of look at individual days to tease out problems. Was there an area where you're having lows? Is there an area where your blood sugar was spiking? And if you can go back and tie it into what was actually happening in your life, that can be useful on those days. And then lastly, and very importantly, we always want to remind people to check their alert settings. And so we'll spend some time talking about those as well.
Okay, this is just a picture of what Schaefer was going through. So here's a CGM download. You can see the estimated A1C is 6.6%. The average blood sugar is 139. Standard deviation is 46. So you can see this person is achieving the goals right off the bat. And time in range is above 70%. Time below range is 4%. So that means the time below range means that this person has been below 70 1 hour a day on average, not every single day, some days more, some days less, during the length of the download. The other thing we didn't really point out to you, but we do to caregivers, is you got to look at the download length. Is it a 30-day download, a 2-week, or a 90-day? Then we got time in range, 73%, and then time below range, 4%. The time below range is important. We're going to go through a bunch of cases, real life cases, and you'll see that you could have a great time in range, but way too much time below range. Now, the other thing I'll just say quickly is that I've been talking about the GMI, which I really hate that phrase. To me, it's the true A1C. The laboratory value is the estimated A1C. And all kinds of things can give you a false value from the lab of the A1C, whether you have anemia, kidney disease, liver disease. Certain ethnic groups have abnormal A1Cs. And if you take your blood and send it to 5 labs to measure the A1C, you could be off 0.7%. So all I'm saying is you got to look at the 90-day, and that gives you a much better indicator of your long-term diabetes control. Take a look at these two curves. This emphasizes the importance of glycemic variability. And this is why standard deviation is so important. In the upper slide, patients bouncing all over the place. And the lower one, patients are tight. Standard deviation is really tight. And basically, they have the same A1C. So that's important. And the A1C doesn't give any information on glycemic variability.
And you guys have seen this before, but just as a reminder, these are sort of the different time and range cutoffs. So TAR is time above range. That's that area in the orange and yellow at the top. So there's time above range that's really high, which is greater than 250. And there's this time above range, which is anything greater than 180. And that green area is the sweet spot. We want that as big as possible, as much time in range as possible between 70 and 180. And then the red ones, of course, are time below range, less than 70 and less than 54. And we really want to minimize those. So these are basically the guidelines that recommend the amount of time that should be spent. But more in green, the best. very important to minimize the time below range in red, and then everything else is the time above range, which we try to minimize sort of over time.
Yeah, and they do have ranges for people that have other serious medical problems, heart disease, and they're not as stringent with the time and range, like over 50% is the goal, but they're very stringent about avoiding hypo. And of course, if you're pregnant, mostly women, they try to make, tight control during gestation is important. Now, this is an old slide, but it represents this, what a no-hitter is. A no-hitter is basically you're between 70 and 180 for 24 hours. And if you think about it, 70% is the goal, right? Time and range. That's 17 and a half hours. That's many hours where it's acceptable to be out of range. So this is the definition of no-hitter. And basically, it is a rare event.
It's hard to do. Yeah, so Jerry Pettis, I think, had a couple no-hitters. He's probably sent them to you anytime he gets one. But he's had more than the Padres. So for Padres people, you must be a lot of San Diego people that are here, and everyone else is just stuck here, I'm guessing, at this point. But so if you know anything about it, who's Padres fan? Okay. Anybody know how many no-hitters in Padres history? I had to look this up. I didn't know this off the top of my head. But I'm just curious. One is right. Who was it? Joe Musgrove. If I had a T-shirt, you'd get it. I don't have one, but
Jeremy had one last week. For
yeah. So it's this hilarious picture of Jeremy. You mean?
Okay.
Yeah. This specific one, will this be on the website?
Yeah, we're filming this now. People are watching online that couldn't make it back, and this will be enduring.
It will be listed.
And Schaefer and I gave a lecture very similar to this called "Think Like an Endo." Okay, you're welcome. So
this is not a case yet, but this is just to kind of really point out what we can learn from the 24-hour modal day at just a quick glance. So it's very obvious when we look at this person that something's going on overnight, right? So the 24-hour modal day, it starts. Does it show up there? So basically, it starts at midnight, 12 a.m., and then it goes all through 24 hours a day, and then it's midnight on the other end. So, right through this is the middle of the night. And so sometimes that may mean different things. So then you have to figure out, what does that mean? Is this person, maybe they're working the night shift? Maybe they're an ER nurse? Maybe, I don't know. We don't know what the backstory is.
Well, this is Dr. Pettis' patient.
Yeah.
And
we'll actually show it again.
We're going to show the case.
But the point is, it's very easy to zoom in and see this spot.
And this individual is, I'll give you your choices. You can think about it. He's a male stripper, a bartender, or a policeman. He's one of those. Okay.
It's not any both.
So this is extremely important, and many providers don't know this, but alerts and alarms, when they're set correctly, can make a huge difference on improving your CGM metrics, your time and range, your estimated A1C, your glycemic variability, just by the way you set your alerts, especially the upper alert. And a lot of folks do not know how to adjust their insulin dose based on the trend arrows. So a little word about setting the alarms correctly.
Yeah. So this one, I mean, when you glance at this one, it's obvious this person is high most of the time, right? Average blood sugar 220, high all throughout the day, above range. So if we glance at the alerts up in the sort of upper right-hand corner of the screen, we see, so first of all, thankfully, they do have alerts. They're turned on, which is good start. The low alerts at 80, right? And I think that's a good, very nice place to be. The high alerts at 390, which is useless, basically. It might as well be turned off. And so there's no wonder this person's just running high and happy to be in the 200s. And so this would be a time to start sort of like backing off on that alert. You can actually use it for something.
Yeah, you defeat the purpose of wearing a CGM when you don't have your high set correctly. And every time I see a 24-hour modal day like this, I just say right away to the younger doctors who are maybe presenting, I said, what are the alerts and alarms? And they look at me like a deer in the headlights. Oh, I didn't ask. Okay. Well, here's the thing. I know that people hate alerts and alarms. Bill Polonsky's here. He hears people get on the couch in his office. They whine to him that they can't get any sleep. The partner wants to leave them, and they drive you absolutely batty. But you have to change your attitude about these alerts. And if you lower your upper alert from the typical 180 or higher to 150 or 160, I know you're freaking out right now, you can actually make major improvements in your time and range.
What if you lowered it from 390?
Yeah.
I mean, you know, it's a joke, but if you went from 390 to 250,
yeah,
it can help. It will be meaningful for that person.
No, that is not a joke. You know, when we see someone that has it that high, we don't go all the way down to 150.
Yeah.
But when people say, I want to improve my time and range, and it's set at 180 or 200, I talk to them a little bit and I say, you know, bring it down. And the bottom line is, get, as I said yesterday, some of you heard me, get rid of the sound that comes factory set. You know, pick a more palatable sound. You got choices on the sounds. They're much better. And I can tell you that by lowering your upper limit, you know, from like 180 to 150, you will improve your time and range 10%. And that's not a small thing. That's 2.5 hours a day. And so basically, this is a picture, a snapshot of the Dexcom sound options. You go into the alerts, you pick high, then there's sounds. And there's, I picked the nerd sound for a while, but you know, this one is my absolute favorite. Eric, when you want to, let's play it. Come with me. Well, that's not it, but that's better. Okay, nice. Let's keep going. You heard the baby crying.
The baby cry is what it sounds like. It's terrible. So there's other things you can do with your alerts to make them more palatable. And one of the things that to think about is you can schedule nighttime ranges that are different than your daytime ranges. So if you really want to be more aggressive, for example, during the daytime and set your high alert at 150, you're going to be awake, you're going to be dealing with high blood sugars, you can bolus for it. But you want to let you or your significant other get a little more rest at night, and you want to raise that nighttime target, for example, to 180, you can do that. So you can kind of play with them that way to fit your own lifestyle.
See, that person needs to change their alert sound. Okay, we have to keep moving to stay on time. But we do have a little bit of 15-minute extra, so not 10 minutes extra. Okay, this is the other thing about trend arrows. You all have trend arrows. The definition is different for each CGM, but they're similar. For example, if you have diagonal up right here, that means you're changing 1 to 2 milligrams per deciliter per minute. That's 30 to 60 milligrams per deciliter points in 30 minutes. And then 1 arrow up, it's 2 to 3, and 2 arrows up is 3 or more. So how do you bolus looking at the trend arrow? And some of my patients, they come in, they say, oh, I didn't understand what that arrow's for. So with Jeremy and we did a long study. We came up with these guidelines that basically, that was my softer sound. If you have a blood sugar, let's just say 200 with a trend arrow diagonal up, you add 50 to that and you correct your number for 250. If you have 1 arrow up, you take 200, you add 75, you correct for 275, and so on and so forth. And on the way down, if to be safe, you wait till the trend arrow eventually turns parallel, stays at parallel for 3 cycles, 15 minutes, to make sure you're not just getting a quick trend arrow change. And then you find out what level you're at, and you can adjust or bolus or correct for that level, depending on what that level is. So it's very important, especially for folks on MDI or people on pumps that are not part of a hybrid closed loop system. It's a little bit different story if you're on a system that does automatic insulin delivery. Okay.
Cool. So let's look at a case together, and just you know, Steve has a lot of asides, but he's telling me to move faster. So, but we will just kind of quickly go through this. I do want to just on this one, we'll just talk through it really fast, and this is how we would look at it. It takes 15 seconds. Average blood sugar 188, slightly above maybe the general goal. Standard deviation 74. Also, we can improve. We're shooting for about 50 or less on that one. Time in range in the green, 50%, right? So there's some room to improve. Time below range is less than 1% or 1% time below range. That's great. So there's not a lot of hypoglycemia. So I'm very happy with that. And then if we just put our eyes down on the bottom of the slide onto the 24-hour modal day, if you recognize that, that's the one that we picked up earlier. And we see that basically in the middle of the night, there's a lot going on. There's a lot of glycemic variability, and that's where a lot of that time above range is happening. So that would be the thing that we should focus on. So if we zoom in on this person and look at each individual day, we see that at nighttime, right about 1 a.m. every night, the blood sugar just shoots up, and then it kind of stays high all night long. And what's actually happening here in this individual, they're not a male stripper, But this is someone who actually snacks at midnight or 1 a.m. every night without bolusing. Pretty much every night. Now, I say pretty much because actually on the nights that they don't do that, they go low. So this is a learned behavior. So this is a person who's trying to avoid low blood sugars over the night. So they don't want to have a low, so they snack every night. And this is how they've learned to sort of keep themselves safe and out of trouble overnight. So why is this happening? They're going low if they don't snack every night. They have too much basal insulin. Okay? So if we just looked at those high blood sugars and you weren't careful, then you might think that this person needs more insulin overnight. And that's exactly the opposite problem. So what we did in this case is we reduced the basal insulin by 20%. We eliminated the need for this mandatory bedtime snack, which should not be a thing anymore. And the time and range increased from actually about 50% up to 64% just with that change, because this person was no longer having the snack at bedtime. So this is what you can learn by quickly seeing where the issue is and zooming in on it.
How long did that take? We still charge you the full amount.
So some takeaways from this case. So type 1 diabetes does not require a bedtime snack. If anybody's still telling you that, send them our way, we'll talk to them. If you are going to snack, give a bolus, right? So in this case, this person was snacking to avoid lows. That's a little bit of a different story. But if you're having a snack because you want a snack, make sure you're covering your carbs. Nighttime highs do not necessarily mean you need a higher basal rate, right? In this case, it was the opposite situation. And really, there are ways to kind of determine if your issues overnight are related to bolus versus basal insulin. And a good approach for that is doing a basal test, which I'll kind of talk you through. And if you are high overnight, so even let's say you're high overnight, but you're not snacking, it may be just residual highs carrying over from the evening. So if you have a big dinner and you end up high and you just stay high overnight, that can be also a problem. So it may not be the basal insulin. It may be that we didn't correct for the nighttime insulin or didn't cover the dinner well enough.
Okay.
So how do we know if your basal dose is right? So we can do a basal test. And this is just a quick sort of approach to doing that. So on a day, you're going to try a basal test to see if your basal insulin is appropriate. You have an early dinner. We want to do the test on a night when your blood sugar is pretty much in range after that dinner time, and you want to have a flat trend arrow. So you don't want your blood sugar on the way up or on the way down. You want it within goal and pretty much flat when you're going to bed. Take note of what your blood sugar is. This is much easier if you have a CGM. If you're poking your finger, you're going to have to poke your finger throughout the night to get an idea of what the trend is. But with the CGM, all you got to do is go to bed, fast all night long, don't snack. Wake up in the morning. Sometimes you can actually prolong this if you want to continue to see if that basal dose is working for you. And then the ideal situation would be when you wake up in the morning, that blood sugar should be plus or minus 30 from what it was when you went to bed. In other words, it should be pretty much flat. It can trend down a little bit. It can go up a little bit. But let's say if you went to bed at a 200 and your basal was perfect, let's say especially if you're given like an insulin shot, you should wake up around 200. If you go to bed at 200, and you gave yourself a Lantus shot and you wake up at 100, that's too much basal. That would have made you low. And lastly, don't make decisions based on one day. So it's good to check for trends, and you can do this a couple of days in a row to kind of see.
Thank you. That's an important point. A lot of people never test their basal. And you can test your basal during the day, but you have to either fast as long as you can till 2 or 3 o'clock, or have a small breakfast and then follow the postprandial, make sure it's good, and then just fast the rest of the day. For some of you on intermittent fasting, you can do it during the day. It's important. We build everything on top of someone with a good basal rate or a basal dose of their long-acting insulin. Okay, case number 2. Estimated A1C, 5.7. Average glucose, 98. Standard deviation, 34. Look at the time below range. It is 21%. And that's basically more than 5 hours a day below 70. And you can see there's a small 4% below 55. Now, if you just look at these numbers, you say the time in range is above 70%. All the other metrics are good, but this person is getting low a lot. And you can see the bottom part of the 24-hour day, the modal day. It's all the little red things low all day long. This is probably a patient for Bill Polonsky. I know Bill's here. I gave her your cell number. And there are a lot of folks like that just are so scared to death of complications. Here's her settings. You can see her low alert is 65, way too low for most people, including her. And her repeat low is not set. And that's important. You got to set those because we usually do 15 minutes because you want to make sure your trend arrow is at least flattening out or on the way up. And the other thing is this lag time. Just to let you know what that is in a nutshell is that when your blood sugar is dropping, the CGM reading is lagging behind what's in your actual blood going to your brain. It, depending on the CGM device, 10 to 15 minutes. So when you hit 65 with an arrow diagonal down or straight down, you're probably 40. So it's important to remember the lag time. It's the opposite direction going up, but that's not a dangerous situation. Okay, so Dr. Pettis adjusted the low blood sugar, put on the low repeat, switched pumps to a hybrid closed loop system. So she previously was on a dumb pump. We call that pumps that don't communicate with a CGM. You like that? And she got a lot better. You can see that, she's now down to, half that amount, time below range. And you could look at her 24-hour profile, there's still lows. And when you look at her tandem control IQ download on individual days, I'll just cut to the chase. Every time you see one of those arrows, that means the pump was suspending because it was predicting she was going to get low in 30 minutes. And that's a lot of suspensions. That's just one day. And what we did for her was, what Dr. Pettis did, I should say, is that he changed her insulin sensitivity factor. And that's an important metric. To me, all the providers are different. That's the most important setting on your hybrid closed loop. It tells the algorithm that 1 unit of insulin will drop you a lot more than if your sensitivity was lower. For people that are resistant to insulin, a type 2 on a hybrid closed loop, their insulin sensitivity factor may be 1 to 25. And I think that's the most important setting. Yeah, we're going to adjust her basal, but remember that that's an important setting. So what did we learn? A good A1C does not mean good control. This woman was in danger. Always review your percent time below range, not just focusing on time in range, which we seem to do at these meetings. Alerts and alarms are your friends. Make sure they're set correctly. Do it in steps, as Schaefer suggested, so you can become adjusted. And these hybrid closed loop systems can reduce hypoglycemia. And that's an important issue. And that's why practice of type 1 diabetes is changing. And everyone with type 1 diabetes should have a glucagon kit. I'm not going to say more than the fact that we have much better formulations. We got the nasal spray, Baqsimi, and Xeris has 3 ways you can give their glucagon preparation, which is pre-mixed, stable in solution, good for 2 years on the shelf. The Gvoke HypoPen is kind of like an EpiPen, but a lot of people like this vial and syringe. And I hope no one from Xeris or the FDA is here, but people are now experimenting with mini dose glucagon. You don't have to give yourself the whole dose. And one of these days we'll have a glucagon pen. Okay.
Cool, another case. So real quick, let's look at the numbers. So average glucose 144, standard deviation 38. Those are both great. Time in range, 63%. So there's a little bit of room to improve in the time in range. Not a lot of lows, only 1% time below range. So if we look at the 24-hour modal day, is there a time point literally a point that sticks out to you guys? Right? So
it took him 30 seconds to get to that point.
It's lunchtime.
I just add one thing.
Yeah.
The standard deviation is 38. The goal is less than 50. When you have a tight standard deviation, that makes it so much easier to fix the problem. Mm-hmm. So that is a key number. It just means you're more consistent from day to day.
Yeah, this person's very consistent, and that standard deviation is very tight. Things get a little crazy during lunchtime, and that would be the thing that I would focus on here. So this is what we like to call a shark attack, and I'll show you why. So it's a shark fin, right? It's that pointy post-meal, after-meal spike, and then followed sometimes by a rage bolus. You just need to get that big spike down, and it usually ends with blood in the water. And you can see how down at the end there's red.
That was good. That was good.
So that's a shark attack, and so this is it's a tough thing to deal with, and depending on your diet, this person's consistently having a shark attack around lunchtime. So this is what we need to kind of figure out in this case. If you guys have come to these talks before, you may have seen this graph. We love this study. It talks about the importance of pre-bolusing. That's the whole point of this. This was a study in type 1 diabetes where they gave the participants the same meal 3 different times and the same insulin to go with that meal each time, but all they did was they changed when the insulin was given relative to the start of the meal. It was either given 20 minutes before the meal, right at the start of the meal, or 20 minutes after the start of the meal. And what we can see is that if the insulin is given after the start of the meal, 20 minutes late, or even at the start of the meal, we can't prevent that spike. It's too late for the insulin to start working. But if we give insulin 20 minutes before the meal, it really cuts off that shark attack. It prevents that post-prandial rise in blood sugar, and that's what we want to achieve. So that's what we're trying to do. So we need to pre-bolus.
Just a quick second.
Yeah.
We went over that quickly. That's the single most important thing you can do to prevent your post-prandial rise. And so
that's true for pumps. It's true for injections.
How do you remember? That's a whole different story.
Yeah.
Please.
So when you can pre-bolus. These ultra rapid acting insulins can help a little bit with this. They do kick in a little bit faster. Some people notice the difference, some people don't. But it's something that we're trying. If you're having trouble with those post-meal spikes, or having trouble getting your pre-bolus in on time, you can try these and see if they're helpful. Fiasp and Lyumjev. Inhaled insulin Afrezza, we've talked about this already. This weekend is a great option. This is the fastest insulin by far. So this graph shows these are not blood sugars, but these are insulin concentrations. So basically showing how quickly that insulin gets in your body and is working, and how quickly it leaves. So in the white sort of circles, that's the Afrezza. It shoots up within minutes. It's working. It's in your body, and then within about 90 minutes, it's already starting to be. It's basically gone. The effect of it's gone. It's getting out of the system. So it's very effective, and it's the closest thing to the insulin that would be secreted from the pancreas in terms of getting in your system and working. So for high blood sugars, or for a high carb meal, this is the fastest way to do it. It doesn't really require any pre-bolusing.
In our video vault for type 1 diabetes, Jeremy gave a great lecture on Afrezza and how to dose it. Super important. Okay.
So what can we learn? Bolus 20, 30 minutes before your meal, whenever you can. Afrezza is the exception. You don't need to because it's so fast on. Set your high alert so we can detect these rising blood sugars. We want to detect those before they get too high. Take the trend arrows into account when bolusing. So Dr. Edelman sort of talked us through how to use that. And if you want to do the math, it can be really helpful in order to correct for trend arrows when they're going up. Try inhaled insulin, or try some of these rapid-acting insulins, and they may help sort of with these postprandial spikes. And you can always try going low carb, something else we've kind of talked about a little bit this weekend. It gives you more room for error. You're less likely to have those spikes after meals. You don't have to be quite as precise with your dosing. So that's another good strategy.
Okay, thank you. We got 2 more cases. We're going to go over our little time frame because we do that at a 15-minute block, but our stuff is important. So,
it's worth
okay, case 4. You can see right away the average is 219, standard deviation almost 100, estimated A1C 8.5, time in range 33%, time below range not too bad. And then you look at the 24-hour profile. I mean, the first thing I notice is that they're getting low. In the early morning, right about here, and the rest of the day, after their first meal, they're just high all day long. And that's giving rise to those metrics.
This is a really cool pattern because there's a lot of standard deviation, there's a lot of stuff going on, but it's also very consistent. I mean, that pattern is there. Low every night, high every day.
Yeah, and you can see the height of these rectangles rarely represent standard deviation.
Mm-hmm. Yeah, the column sort of around the average blood sugar.
Yeah, so right here is a tight standard deviation. This standard deviation of 97 is an average for 24 hours during the length of the download. And that's why looking at individual days can sometimes be helpful. So 32-year-old, longstanding type 1 diabetes, obviously on a CGM and someone taking shots. He takes 40 units of basal insulin per day and rarely boluses for meals. So what can we learn from this case? Your basal rate cannot cover meals. I think that's pretty obvious. Increasing the basal rate, which a lot of people do in place of rapid-acting insulin, can definitely lead to lows, especially during periods where you're not eating. And you saw what happened in the early mornings. Missing the meal times, boluses are important. Focus on the biggest meal of the day. Start, a lot of folks, and I know a lot of Bill's patients are afraid of getting low. So he sometimes eats with them and they bolus in front of him, then they pay for the bill. Then you should set your high alert correctly so that even if you're not bolusing, you're notified early, you can give a correction bolus, and consider the benefits of our hybrid closed loop pump. Here's the same view, just emphasizing this person is getting low. What was happening here? Increasing the basal to cover meals, and we call that over basalinization. It's really hard to say 10 times in a row, but this is what happens.
This is an extreme example, but we see this a lot, in less extreme versions where people are still relying too much on their basal insulin and not giving enough with meal times. So, even if you kind of shrink this down and make it less extreme, it's actually pretty common.
Yeah, if you did a overnight basal test, this person would really get low.
It'd tank.
Okay.
Okay, one more case here. So this is a little different. So this is average glucose 132, standard deviation 28, time in range 94%. Look at the 24-hour modal day. This person's killing it. It's basically a no-hitter every day.
Yeah.
But what's going on here? So this person does have type 1 diabetes. They're 44 years old. They were diagnosed about a year ago. They had positive antibodies. They take about 10 units of basal insulin and occasionally 1 to 2 units with their meals. But this is someone who has LADA, right? And so this is latent autoimmune diabetes of adulthood, and they're in their honeymoon phase. And so where's my LADA peeps? I know you guys are in here. Yeah, good. So this is a slowly progressive form of autoimmune diabetes. It is type 1 diabetes. It's characterized by adult onset, and they say usually in the age greater than 30 to 35. We know that's not always the case. It can be younger than that. It definitely can be older than that. It can be any age as an adult. And there are positive, in most cases, they're positive autoimmune antibodies. So this is type 1 diabetes. What's different about it is there's a variable rate of beta cell decline. So this honeymoon period can last for sometimes an extended period, sometimes months, sometimes years, sometimes many years.
Longer than your real marriage.
Also variable rate of decline. These folks may not need insulin at diagnosis, and they're often misdiagnosed as type 2 diabetes. Not necessarily, but it's a common story, unfortunately. But eventually they need insulin, usually within 5 years or so.
Okay, we're finished. Let me go through the concluding comments, and then we'll step off the stage and answer some questions while they set up for our next panel, answering all the questions. And Schaefer will be up there for that too. Having a CGM does not automatically mean good control. That is important. You don't just slap it on and you're done. Learn how to interpret the CGM metrics yourself, and learn what your goals are for time in range, time below range, variability. The upper and lower alerts are your friends. Don't keep fighting them and turning them off and raising them high and too low. And understand how to react to the trend arrows. And lastly, create a dialogue between your endocrinologist, your healthcare professional, your mother-in-law, whatever. Go over the data together next to the computer where the CGM is up or on a sheet. Okay, thank you very much. Thanks, Schaefer.
Thanks, guys.
Awesome.